Hubbard Foundation sponsors a multi-center registry in the United States. It's possible to be used in Canada, but that has not happened yet, so we have 26 sites around the country. My colleagues have been a neuroscientist at UCSD, Dr. Idris Baracus, and our stats are done by Heidi Sauer from Denver, Colorado. The interventional radiologists that we use, Dr. Ponick, Liddy, and Saxon, are in San Diego. And then it's important to point out that our research is not funded by an outside source. Patients have to pay for the testing and treatment themselves. So overview, I want to just quickly start off by talking about where I see things with the autoimmune theory. When my son was diagnosed with MS in 2009, I went to the library, I went to my colleagues, and I was devastated because I didn't think we had made much progress in 50 years. So I want to talk about the oligodendrocyte apoptosis, which means death. It's something that Dr. Stice also alluded to. In fact, I have a feeling we have quite a bit in common. Talk about brain hypoperfusion and CNS venous drainage. So far, I have not even mentioned CCSVI. What is the blood-brain barrier? What does it mean to be permeable or not? Then I want to describe our own research using fMRI, which is a method to look at brain activity, and our studies of perfusion. Then kind of talk a little bit about what venoplasty is. I think this group knows what it is. Let's talk about that a little bit. Then I want to describe the first 260 cases that we have completed being tested and treated for CCSVI. This paper has been accepted by the Journal of Vascular Interventional Radiology, and then conclusions and recommendations. So first of all, I think it's always kind of important to remind ourselves these drugs don't work that well. Yes, they're statistically significantly effective. They are able, they meet FDA requirements to be approved. Look, that's a tough slide to look at, but if you look at it in the graphical form, on the darker squares are the results of the DMV. So each of these are a different DMV. Not a great slide, so it's hard to read. There's beta interferon. So white is the placebo rate. So annualized relapse rate on placebo versus on the drug. So overall, it's about a 33 to 38% improvement. Bulimia may turn out to be more effective. It's $48,000, and Copaxone has just increased its price from what used to be $12,000 or $15,000 to $43,000. Very expensive. Very. I mean, obviously you're not paying that, but still, that's a lot of money. So, what are we trying to figure out? This is my son's first MRI. These are the lesions we're talking about. So what is going on there? The trouble with the MS research has been that usually you have to wait until the patient has died and then look at their brain under a microscope. But obviously what we really need to know is what's happening at that first moment. What's happening in the hours or days after the lesion? What is happening right in those spots? What is happening right in those spots? That's really what we need to focus on. So this is how I look at the world. The standard MS theory, the autoimmune theory, is that white cells are leaving the blood vessels and attacking intact myelin, right? That's the autoimmune theory, that these white cells are attacking myelin. So there's the neuron, there's the oligodendrocyte wrapping around the myelin. Zamboni. Zamboni is a name you recognize. Zamboni is famous for this procedure, but really he's an amazing guy, actually a sweet guy, whose theory is that because of sluggish flow in the venules, the red cells are able to cross the blood-brain barrier, get into the adjacent tissue around the vessel, and that these red cells break down, that iron accumulates in the tissue around the myelin, and iron is toxic to oligodendrocytes. This theory is really not about what's going on in the neck, right? Ultimately, we're not here about our neck, right? We're here about what's happening up here. I have a variation on it, so I just call it the Hubbard theory, which is that, in fact, what's going on is that the myelin is dying first. It's not that the immune system is attacking myelin. It isn't even that iron is causing a problem, but that, in fact, the myelin is dying first. This is really not that different than what Dr. Stice described to you earlier, and that the white cells are coming in to clean up the mess. So, oligodendrocytes die first. This is the work of Prineus and Barnett. Prineus is retired now, but one could consider him to be the preeminent neuropathologist studying MS for the last 30 or 40 years. And what he's shown is that, so what we have here, I'm only going to do a few of these. This is not my own research, but I want to kind of get a feeling for what the problem is we're trying to solve. So over here is normal white matter. Over here is the beginning of a problem. And over here is phagocytosis. So over here we have normal-looking cells. What we see here, that black dot, that black dot, that black dot, those are the nuclei of oligodendrocytes, the cells that make myelin, dying. They shrink, they become what's called pycnotic. They're dying. And then finally, over here, we start seeing a mess, and the mess is white cells coming in. They're a particular type of white cell. They're macrophages, or activated microglia. Why does that matter? Because those are the leeches and the maggots of the immune system. They're part of the innate immune system. All the focus in MS has been on T cells, in particular helper T cells, which are part of the adaptive immune system. They come in to orchestrate, to enhance, to modulate, to make better or worse. Macrophages are there all the time. They're the pus in your skin when you get a cut. They come in to clean up these guys. When these oligodendrocytes die, the macrophages and microglia come in to clean that up. This is also from the same group, and I really like this slide because what it's showing is, and Dr. Stice has even a prettier picture, but this is the myelin around an axon. And look at how the myelin is unsheathing. It's falling away from the axon. This myelin is not being attacked by white cells. Right? All the MS drugs are trying to kill white cells. Right? These guys aren't even being attacked by any white cells at this point. They will be. Macrophages will come in and start gobbling up the broken down bits of myelin. This is from that same group. So now it's looking at it schematically. Here's an oligodendrocyte. It's wrapping around a myelin. The first thing you see is the nucleus becoming dark, called pycnotic. This is a oligodendrocyte starting dying. Then we have the microglia. So here's a normal microglia. This is an activated microglia. That's the beginning of the local immune attack. This is not the systemic immune system coming in to modulate. This is local activity. And then finally, you see macrophages coming in to start cleaning up the myelin debris. So, blood-brain barrier. So what's the deal here? So we have very small blood vessels that are surrounded by brain tissue, and in particular, the brain tissue we care about particularly is the oligodendrocytes, the cells that make myelin. There's also the neurons, the axons, another cell group called the astrocytes. So this is the blood vessel itself, and it's surrounded by this elaborate structure. The endothelial cells, this is an endothelial cell. Just outside that is a periocyte, which I sort of think of as sort of a very small, smooth muscle cell. Then you have a basal membrane, and then you have the astrocytes. See the astrocyte foot? This astrocyte comes out and surrounds this. And so this structure is what's allowing stuff to get through. So you hear the term blood-brain barrier breakdown. But in fact, it's actually not breaking down. It's becoming more permeable. When I first heard about this, and when I even hear somewhat academic people talk about blood-brain barrier breakdown, one visualizes that the wall, the vessel, think of it like a plastic tube, is deteriorating. That's not what's happening. The lining of each of these endothelial cells is allowing things to go through it. It's a very selective process. So what actually happens is what's called rolling and adhesion and entering. So the white cells attach to the lining of the endothelial wall, get sort of stuck to it, and then they're allowed, they're not breaking through, they're permitted through into the tissue where the myelin is disintegrating. That's sort of another picture of the same thing. The leukocyte, so that's white cells. Not lymphocytes, by the way. These are not the cells that modulate the system. These are the PMNs, the leukocytes. They roll, they get attached, and then they're sucked through. So why is this happening? So this is, to me, my favorite slide by the Prineus group. They're currently in Australia. So we have this whole elaborate process, the microglia being activated, the phagocytosis beginning to attack myelin, all this stuff happening. But look at the very top thing. Unknown factor. Right? Dr. Stice was leading this too. Everything for 40 years is focused on the massive immune attack. I like to think of it as, I had bad acne when I was a kid. You can see the scars from there probably. It always made me mad to see my friends with whiteheads and blackheads who didn't even bother to wash their face. If I allowed a white blackhead to be there for a day, I would get a pimple, and sometimes a really bad pimple. To me, what's happened is we focused on pimples and not focused on the blackheads. So we need to know what's happening right up there. So I think the answer may be in what's called perfusion. So there have now been 6 or 7 studies on perfusion. What is perfusion? Perfusion is not the blood flow in the blood vessels. It's the flow of fluid through the brain. It's actually technically the flow of water through the brain. The technique we use, arterial spin labeling, you can label magnetically the water in the blood flow coming into your brain, and then you can follow how long it takes to move through the brain. Not just move through the blood vessels, but move through the brain where the oligodendrocytes are. There have been a number of studies. This was probably the oldest one from 2004. And basically what we're seeing is that in various areas, the periventricular area, that's where a lot of the lesions are, intermediate areas, you see a very clear less perfusion in these areas than in normal. So we've known since 2004 that perfusion through the brain is abnormal. The assumption has always been that it's slow because there's brain atrophy. Because there's already been loss of brain tissue, then the idea would be that therefore you don't need as much flow, and that's the reason for the hyperperfusion. So I'm just going to quickly visually show you a couple of studies to make the point is it's settled that there's hypoperfusion in MS. This is a different way of looking at it. You can look at the levels of activation in these little circles, and basically what you see here is areas where there's increased perfusion, and then in the green areas where there's decreased perfusion. So there's a redistribution of it. This is actually from Zamboni, where he was comparing perfusion to whether or not someone has abnormal CCSVI. CCSVI is a Doppler definition, right? It doesn't mean poor blood flow in the brain. It means a certain criteria when you use a Doppler device as to how many blood vessels are going at a certain speed. Part of the problem with this debate has been, it's all been focused on what's the right Doppler technique, what's the right ultrasound technique, what's the right MR immunography technique, when really that's not the point. The point is, what's the underlying theory as to what might be going on? So once again, another study showing decreased perfusion in MS. So this is what the procedure is. I think this group knows what the procedure is, but basically, it's really a rather trivial procedure. So we've done 500 cases altogether. I'm going to present our first 260. We've had no serious adverse events. There have been a few horrible adverse events. In general, they've all been due to bleeding, due to anticoagulation, not the procedure itself. The procedure itself is really quite straightforward. You put a catheter in the vein in the groin. You wind it up. You wind it all the way up into the internal jugular vein, or the azygos vein, which drains into the heart. You see if you can see an area where the valve is stuck or it's narrowed. You put a balloon in and you blow it up. It's done for dialysis patients, thousands a day across the United States, incredibly safely. It's really a rather trivial procedure. In fact, at least as I see it, the reason the vascular theory of MS has gotten exciting again is that now we have something you can do about it. Before, a few years ago, there was nothing you could do about it. I mean, they thought there might be a problem with the vascular drainage of the brain. Interventional radiology, they got a nice gimmick here. They can do non-invasive procedures. To do something to the vein before, you would have had to cut open the neck, stop all the blood in the area, because otherwise you'd bleed, and do something. Now you can just do it from the inside. Endovascular, internal vascular. So that's what the vessel looks like. This is the balloon you put in it, and then what you try to get is you try to get a result where you have less narrowing. You do the same thing in the azygos vein. You start off with a sort of an ugly-looking azygos, either with valves in it or with narrowing. You put a balloon in it, blow it up. It takes minutes to blow it up, and then afterwards you look to see whether you got a result you like. I don't do the procedure. I'm a neurologist. This is what the procedure looks like. This is MR venography. This is what the veins look like. So basically what you're looking for is the number of collaterals that you see and whether you can see asymmetry and or constrictions in the pattern of the veins coming out of the neck. So you can, some people focus on Doppler and ultrasound, others, including us, we do MR venography. But if you just go to any regular MR suite and ask for a MR venography, it'll almost definitely come back normal, because there's no agreement as to what the normal anatomy of the vein is. If you just think about the veins from the back of your two hands, they're not the same on both sides. So a traditional neuroradiologist will look at these pictures, no matter what they look like, asymmetrical, with or without collaterals, different sizes, and say, well, that looks normal. So it becomes a problem. But the key is also measuring the flow in these veins. So I reasoned when my son was diagnosed, and I met Zamboni and Dake and all these folks back in 2010, that maybe my machine can be helpful here. So what chance was it that I would have my own independent fMRI research facility when my son gets diagnosed with MS in 2009? So fMRI is, how fMRI works is MRI is typically a snapshot of the brain. This is a movie of the brain. You take a picture every second, and then you stimulate it. In this case, what we do is we show a clock on the screen, and then in the earphones we say a time of day. And the task of the subject is he looks at a clock that says 8:05, and he hears 9:05. And then with a response, he has to say correct or not correct. Right? So it's an auditory task, a visual task, and an executive task, having to make the decision what to do. So you get a look at all different parts of the brain in response to that task. So I reasoned, don't like my border here. So when you do that, you get a surge of blood. So this is hearing one clock. One clock, one auditory. You see a surge of blood. How fMRI works is the brain is, hemoglobin has iron in it. Iron is magnetic. So you can see a surge of blood when a person does a task. So this is one task. This is a series of 8 tasks. And what you see is there's a surge of blood that comes in, and then it plateaus off, and then it goes down. And what's been known for 10 years is that after it goes back down again, it goes a little bit below baseline, and then it flattens out. So this is called the venous undershoot, and it's known that is caused by the delay in the blood leaving the area. So when you activate it, blood surges in, it surges out, it goes a little bit slower, and comes back out. So I reasoned that if there is a venous drainage problem, that it ought to be a little slower and a little longer. It should take longer to have that response again. So basically, this is what the images look like. This is a control subject. This is a normal subject over here. These all look like kind of blurry images. This is an MS patient. Actually, this is group data. This is 20 subjects, 20 normals, 20 before venoplasty, and 20 after venoplasty. And so, just looking at it with the naked eye, it's obviously they're different, right? This is the day before venoplasty. This is the day after. This cannot be explained by, for instance, atrophy. The standard thinking about hypoperfusion is, well, of course the blood is going to be going slower because there's been atrophy of the brain. There's not as much brain tissue. That would make sense. Well, that sure can't be explained the day before and the day after surgery, right? You can't have had your flow change. These are obviously visually they're hard to look at. Basically the same. So here is this time what we're doing is a normal subject compared to an MS patient before they've had the procedure and then after. Dramatically different, right? So this is the pattern. This is the comparison showing a longer, deeper venous drain, venous undershoot that then reverses. In fact, looking at it quantitatively, task positive, so that's actually doing the task. The control subjects have much faster drainage. Pre is slower, and then afterwards it comes back. So literally the day after the procedure, these are statistically improved venous drainage. Task negative is interesting. Task negative is it's known that when you do an fMRI study, when you're not doing the actual task, waiting for the clock and picking the right time, you sort of rest in between. It's called the default network. You sort of just, what you do is you daydream. You're sort of waiting for the investigator to do what he's doing, and you're kind of bored. You sit there, and that part of the brain activates. It's called the default network. It's sort of a central middle of the brain, kind of where people, where some people say it's where meaning is, personal meaning is. So anyway, that's even more dramatic. The default network, the kind of personal area of the brain, had an even more dramatic increase in speed of venous drainage from the cortex. This is not the neck, right? This is the cortex. This is where we think. So this is that picture I just showed you. The dotted line is the 20 patients before MS, and the dark line is after. So pretty much everything looks normal here. This is not an arterial problem. It's not a surge of blood into the brain problem. It's a delay. Both it's a deeper and longer delay of blood flowing out of the cortex the day after venoplasty. So that's not a placebo effect. Just looking at sort of mathematically the same thing. So here we have with each of the three lines. The black one is normal. The blue one, hard to see, it's blue, is pre-surgery. The red is pre-surgery. The blue is after. So the difference between pre and post-surgery doesn't look very dramatic, but it's statistically significant in 20 subjects. So there's an altered hemodynamic response in the cortex of patients with MS, an increased venous undershoot. It's particularly prominent in the default network, the sort of the medial areas, and that that angiovenoplasty normalizes that response. It brings the MS patient's venous undershoot back almost to close to normal. So it's a very elaborate system. You have to have a very specialized system to do this. You've got to show pictures and stimulate at the right moment. So more recently, we've looked at arterial spin labeling perfusion. So once again, perfusion is the flow of water through the brain, not the flow of blood through the blood vessels, right? And so, what you do is you magnetically tag it. You can sort of flip the protons in the water, and then you can follow how long it takes them to move through the brain. So essentially, it's a measure of stagnation. And in particular, my reason for being interested in is I'm asking myself, is it possible there's stagnation around the oligodendrocytes? In other words, we need to know what that unknown factor is, right? It's too late to wait until the whole the pimple has occurred. We need to find out why the pores what's the problem with the pores before the pimple has occurred. And so, to me, it was a reasonable model. So, we've now done only 10 subjects at this point. But basically what we're looking at is perfusion in gray matter versus white matter. And so the red line is the mean. So the mean in gray matter in this MS patient is 37 and in white matter 24. Normal should be about 60. 50 to 60 is what normal is. And then you can also see there's a distribution to it. So even though that's the mean, that there's when you look at the cerebral blood flow, so this is no flow up to 100 milliliters per milligram per minute, and this is how much of the brain is involved. There's a pattern to it. But these are what the pictures actually look like. So this is pre-angiogram perfusion in gray matter. There's no point in sort of going through, what it means. We need to mathematically do the calculation, which I'll show you. But basically, down here at the bottom, how much blood flow at different speeds. So I'm just going to show you these quickly. This is gray matter. This is white matter. It's hard to see, but the fact in the white matter, so the gray matter is right along the edge of the brain. The white matter is in between. There's a different amount of flow in that area. This is the gray-white boundary, so what happens at MS is often will be between, right at the edge where the gray matter and the white matter meet, the gray-white matter boundary, another pattern, and then post. So what I'm going to show you at the end is the same pictures, pre versus post, calculating the difference. So you can't just with your naked eye decide what that is, but I want you to see it so you can get a sense of what these pictures look like. In other words, when you get an MS MRI scan, basically you're looking at old and new lesions, right? With or without gadolinium. Gadolinium shows you a lesion that occurred in the last 3 to 4 weeks, 2 to 4 weeks, and the T2 non-gadolinium shows you evidence of a lesion that has occurred at any time in the past. So that's why you're having an MRI scan. Why do we have to do that? It's because if you have a lesion, maybe this is an interesting sort of argument to make, but in general, if you have an attack in a quiet area, and the white matter in the periventricular area often is quiet, you have a lesion in the spinal cord or the brainstem, you're going to have a symptom. You're going to have weakness, or you're going to have double vision, or weakness at one side of the face, like my son did. But if you have lesions in the periventricular white matter, you might not even know you had them. So you need the MRI to look, and so you can count up the number, and that's basically what you do. Once a year, you get to be told how the year went. It doesn't mean treatment's going to change, right? If you haven't had an acute attack, you're not going to be given steroids. If everything seems to be going fine, what's the neurologist got as his options? To switch drugs or not switch drugs, or convince you to be on it, or convince you harder to be on it. That's really the option. We need a biomarker. We need a way to look at what's going on in the brain on an ongoing basis, not just count up the lesions at the end of the year. Not that I have any strong feelings about it. So now, this is comparing post to pre. So what you see, so red is increased, is markedly increased. Light blue, whatever that color is, I'm not good at these fancy clothing color names. What is that sort of pale blue? Is that?
Turquoise.
Turquoise? Okay. So turquoise is no change. Red is increased perfusion, and blue is decreased perfusion. So the first thing you see is, it's not real simple. It's not just that, oh, everybody has red everywhere. It is this redistribution. So this is actually 20 subjects, and this is not what I would have predicted, but it's kind of interesting that there's kind of a splotchy pattern to where you get it. So that's the actual difference in intensity. This is a statistical map. So this is not actually looking at flow. This is calculating significance or non-significance. So red is statistically significantly increased. Blue is statistically the other way, decreased. So overall, the bottom line is it seems to be a redistribution, but it's a statistically significant redistribution. So I guess I'll show you that before. So this is the results of our first 10 subjects. The red line is no change. So pre is what the flow is. Normal should be out here to 60 in general. So here's a group of 10 MS patients. The dots, the marks are, so this patient here, his pre-perfusion was about 42, and the post was about 50. So that is a great response, right? This person's perfusion before versus the day after venoplasty went from 40 to 55, and that's statistically significant. So all the circles are statistically significant. So just looking at it, one patient did go down a little bit, right? It was, say, 33, and now it's 30. And that, because it's a circle, that means that was a statistically significant difference. But in general, both in gray matter and in white matter, we see almost all the icons are above the line. This overall group is statistically significant. Looking at this a little different way, this is normal subjects, MS pre-angioplasty, MS post. So you can see clearly that the normal subjects had a much higher mean. The black is showing you the range, the variability. So looking just at the mean, that just gives you the group result for the whole group. Just looking at it, you see a wider range. So here's the pre. You've got the mean does not, it's actually statistically increased pre to post, but also it's shifted differently, right? We've only done 10 subjects of this, but we're excited about this as possibly eventually being a test that all of you can have. When you next went to get your MR, your annual MR, and in addition to looking at how many lesions there are, you could ask for an extra 10 minutes and probably the same price for the lesions. You could find out where your perfusion is. Maybe it's we're not ready for that yet, but to me it seems like this could be a possible future. So this is the paper that's been accepted for publication in JVIR. It's 260 patients. It's not, the details here are not too significant. 66 were female, 42% relapsing remitting, 14 primary progressive, 26 secondary progressive, 35% were on disability, and then durations of first symptoms, durations of diagnosis. You know, it's interesting to me. It became interesting to me. My son had his first episode in May, but he wasn't diagnosed with MS because you can't be diagnosed with MS until you buy the second attack. So we sat on our hands for 6 months until he had a second attack, and then he bought the diagnosis of MS. So I find it always interesting that we have to collect when the diagnosis was made versus when the first symptom actually did occur. Not that I have any strong feelings about that. Most of these patients were not on disease meds. 75% no disease modifying drugs. So that's sort of a political statement. You know, the people who came to San Diego, 75% of them weren't on medication. Any patient who was on medication, we recommended, asked them to stay on it. Many of these patients weren't seeing neurologists anymore. We measure the flow in the vein. So as we talked about, if you just look at the anatomy is very variable. How do you really decide whether that's really narrowed or a little bit narrowed or that's just normal variation? So we actually measure the flow. Any MRI facility can measure flow, but almost none of them do. The radiology in general is a pattern recognition. The radiologist puts it on the screen, normal, abnormal, right? To measure flow, you've actually got to get out a slide ruler or do some calculations. So it's generally not done. But here are the flows. I show them because these are not good flows. You'd like to see your flows 10 milliliters per second on each side. In general, some folks have 1 or 2 milliliters of flow on each side, but these are our averages, 6 and 4. They're still not what you expect the normal to be. Reflux means the blood's going the wrong way. Circulatory flow means that it's turbulent. It's going both ways. And so not everybody has reflux in the internal jugular. And not everybody, most patients, more patients have circulatory flow. So then this is what sites were treated. 89% had the lower left internal jugular. I won't go through the detail here. This is the typical pattern. In general, everybody who's doing this procedure will do the lower internal jugulars where the valves are. There's a debate about whether you should do the upper internal jugular, whether there's an extrinsic lesion that cannot be repaired by a balloon, whether there is just a narrowing because there's a problem lower down, so there's less flow higher up. Most people are doing the azygos, but for instance, there's a whole ongoing debate about whether you should also look for Meg-Turners, which is really a groin venous problem. So there's a debate: should one do that? Is this a systemic disease, or is this just a brain disease, or really is it not a disease at all? Right? That is still going on, and there's nothing wrong with that. So we use the MSIS, Multiple Sclerosis Impact Scale. This is a validated instrument. It's a self-report instrument, so that the neurologist would say, hey, we like the EDSS because the neurologist does it, so that makes it objective. If it's a self-report scale, it's not as good. But this is a validated instrument. It's used in drug trials. And so what we did is we did the MSIS 29, which has a physical and a psychological score, 2 scores. And we did it the day before surgery, and then at 1 and 6 months after surgery in 260 patients. So P.01. So that is highly statistically significant. 0.05 is the standard point to decide whether a result is statistical or not. So this is 0.01. It's very statistically significant, and it's statistical in all groups. At 1 month in the psychological score and in the physical score and the psychological score, and at 6 months in the physical score and the psychological score. So basically, 260 patients using this validated instrument, we got a statistically significant improvement in clinical outcome after venoplasty. This is the 3rd study that's ever been published. Right? Zamboni's first paper was 95 patients. The second paper out of Cole, I think, was 68 patients. This is the first one published in the United States. So now we have to say right away, not double-blind placebo control. Right? This could be that the patient wanted to believe they were better, and so they scored higher. Right? That is correct. That is true. You can't use data like this to get FDA approval. You can't use data like this to get evidence-based approval in Canada either. So the next thing we did, so here are the scores broken out so you can see it more clearly, because the next question is, how many people get better? How many don't get better? That's an ongoing debate. You sort of hear that about 2/3 get better and about 1/3 don't. Well, here's our actual results. So these bars are that the MSIS has been compared to the EDSS, and so the research on this says that a change in the MSIS score of 8 equals a statistically significant change in an EDSS score. So the EDSS score is a very different score, right? It's 0 to 10. 0 is you're fine, 10 is you're dead. This is goes. I'm not sure what the top score is, 50 or 60. So these bars are breaking it up into that pattern. But basically, 0 is no change. So in the physical score at 1 month, a few patients, there's the numbers, were worse, and a lot more were better. This is at 1 month psychological scores. Same idea. There's your 0 point. 6 months, here's the 0 point, and 4 months. 6 months. So that's where we come. Our overall response on this was 65.7% got better. This is impossible to look at, but this is what's called a regression analysis. What this does is you use this method, regression, to decide to see what variables at the beginning predict what's going to happen at 1 and 6 months. Because that's what we want to know, right? Who should have this procedure, who shouldn't? If only 2/3 are getting better, is it fair to be recommending to the folks who aren't going to get better? We're going to talk in a minute about restenosis and all that, but we'd really like to know that. I don't want to have you focus on this too much, but here's what we got. Women seem to do a little better. Secondary progressive seem to do a little less well. Duration of illness, disability status did not predict. We'd all assume it would, right? We'd think, well, if you've had it a longer time and you're more disabled, you should have a less of an improvement in your MSIS score at 1 and 6 months. We did not find that. Age didn't predict. Whether or not you were on medications did not predict. The other variable that predicted was how many veins were treated. So that's out there in that literature. You know, there are the guys who treat as many veins as they can find in the body. And then there are the ones who are very selective. You know, I'm only going to do an abnormal valve. So that will mean they'll do 3, right? They'll do the lower internal jugular, the left and right, and the azygos. They're going to do 3. Whereas there are other people who treat the renal veins, the iliac veins, multiple sites in the azygos and multiple sites in the internal jugulars. Well, interestingly, the more sites that were treated did in fact predict better outcome at 1 and 6 months. I sort of almost wish that wasn't true, but that was what we got. Okay, so let's just talk about this a little bit more. So we need to know much more about who's getting help and who's not. This whole issue of valves versus stents. Problem with stents, yes, you can keep the vein open, but it will endothelialize. So you're sort of setting a ticking clock when you have a stent, because it will endothelialize. Eventually it will clog, and the endothelial is, think of it as a scar tissue. It is very difficult and often is impossible to ream out once it's scarred in. So, you know, the debate becomes, if you've had a really good response 3 times, should you have a 4th balloon or should you have a stent? I think that's a very tough decision. We covered that. Valves versus stenosis everywhere. So everybody has an abnormal valve. The trouble is 20% of normals have an abnormal valve. Robert Fox at Cleveland Clinic, he did an autopsy study and showed the abnormal valves. They really are pretty good-looking abnormal valves. But what about some of these other narrowings? Are they going to respond as well? Restenosis. So in our study, 6.5% had return of their symptoms. So Zamboni's definition of restenosis was he tested them again at 18 months and saw whether the Doppler had changed. So the definition we used is someone whose original symptoms got better, whatever they were. So sometimes they're very dramatic. Like we only had one patient who literally stopped needing a wheelchair. You hear those stories. We only had one of those. But some people have such an improvement in their fatigue, their headaches, their cold extremities, that for them it's a very dramatic, important change in their lives. So we define restenosis as the symptoms that got better during the procedure. If those same symptoms come back again, that's how we define clinical restenosis. Ours was 6.5%, so we did retreatments in 6.5%. That's a very low number. Just as you hear what other docs are saying, there's a new society, the International Society of Neurovascular Disease. I'm one of the founding members. Zamboni was the first president. Dake's going to be the next president. Zabadinov at Buffalo, he was this last year's president. We had a whole session on this issue. So I think we're not decided yet. We had a very low restenosis rate. Some places are reporting 50 and 60% restenosis rates. And then other veins, so that debate's still going on. Everyone does the lower internal jugulars and the azygos. Should other veins be done? After all, if the basic idea of venous drainage is important, well, it's not going to be as simple as just treating the bottom of the internal jugular veins. We just don't know. Okay, so I mean, here's where I kind of summarize all this. The autoimmune theory is, at this point, unproven. I think Dr. Stice did actually a better job than I'm doing at sort of going into the problems with that. But basically, the wiping out the T cells does not cure the problem. We've never been able to identify an antigen. In other words, that we've never been able to show that the white cells are actually attacking myelin. That oligodendrocyte damage may in fact be primary. Why? So there have been different theories. Maybe it's glutamate, maybe it's nitric oxide, maybe it's iron. But we still have to ask why. Is it congenital that these oligodendrocytes are kind of wearing out sooner? So to me, I think it's at least a reasonable hypothesis that the oligodendrocytes are dying because they're in a stagnant environment, because there's poor perfusion around them, poor drainage from them. Doesn't mean that dilating, ballooning the lower jugulars is going to solve everything, but at least to me, it's a promising hypothesis that deserves attention. In fact, at this point, I'd say Zamboni has already accomplished what he needed, because we're seeing more papers on the blood-brain barrier and on venous issues and on vascular venous disease than we ever did before. All the articles on MS were always about which cool T cell were you trying to knock off. Now we're doing a much broader look at this whole topic. And then, at this point, I think we can say there is preliminary evidence that venoplasty has a place. The problem is, so recommendations. First of all, we do not recommend you stop the DMDs, even if they're focused on the pimple as opposed to the pore. Better, that's worth doing. Double-blind studies are planned. So Saskatchewan's about to do one, sending the patients to Siskin and Albany. My concern is, are we really ready to do a double-blind controlled trial? That's the key. So we don't want to blow it. Which veins are going to be treated? How experienced are the people who are going to do it? There's only, in the United States at least, but in Canada, no one does it. So that's why Saskatchewan is sending them to Siskin. Siskin has done, I think, about 1,000. Stefani has done, I think, maybe a few hundred. Our group has done 400 or 500. Our multi-center trial has done about 500. But experience could end up mattering. By the way, in progression to prediction, we compared our 3 doctors, 3 different radiologists and neurointerventionalists were doing it, and that didn't predict. That would have been tough for them if one guy had much better outcomes than the other 2 guys. Unfortunately, that didn't happen. But the design of that study is going to be tricky. If we think that fatigue and headache are a big part of why people are better, well, then that better be captured in whatever measurement is used. So the EDSS does not capture that, and the MSIS that we use does not really capture that. I think if you're going to have your annual MS MRI looking for lesions, geez, why not at least start asking the doc to do an MRV and an MR perfusion too? I agree it's premature in the sense that we don't have the definitive proof on this yet, but these are tests that are available now. They're used, perfusion is used for stroke fairly routinely at this point. MRV is done routinely. It's just the radiologists think every variation is normal. But I think we should be moving in the direction of when you're ruling out MS, you're ruling out everything: cancers, viruses, blood disorders, the workup, genetic disorders. Why not just add perfusion and MRV to it? That's my own thing. And then I think people should have the right to at least consider venoplasty. At first, the big deal, especially when I was talking at the MS Society of Canada with the vascular surgeon, is, oh my God, this is incredibly dangerous. It just isn't dangerous. There have been a few horrifying cases, but the procedure is basically pretty simple. Yes, I get it that you're not allowed to have it, but if you had varicose veins, you'd be allowed to have them treated. Right? So this, in a sense, could be looked at as varicose veins of the extracranial vessels. It seems to me that you should have the right to have that treated if it's identified. And then, what can you all do? You know, the world has changed with the internet. You know, when I went to the library, I was devastated basically to discover nothing much had changed. And it was my wife who had gone to the internet, and she mentioned this ice skating rink guy. And I didn't buy it. I thought it didn't sound going. And at first, it took me 2 weeks to even read the article. But when I did, I said, you know, this makes sense to me. The big conference was going to be in Hamilton in February of 2010. Everyone was going to be there. So I called up Mark Hakey and got myself invited. And it changed my life. I shudder to think what would happen if I hadn't gone, and my son still at this point would have been traded. He was on Mike Dake's waiting list. He would still be on it because the neurologists at Stanford have still successfully prevented Mike Dake from even getting IRB approval for a fairly simple study. But you all can learn, and I'll tell you, you need to learn about diet and supplements. They're not going to ever get studied the way drugs are because there's no money in it. But there's a lot of stuff out there, and you've got to make your own decisions. It was only a few years ago vitamin D was considered a little goofy. Now even the neurology literature is talking about vitamin D. I myself am convinced by the gluten issue, that not everyone has celiac disease, but there may be milder forms of it. So my family eats no gluten, and I do not think I've suffered for it. I think, if anything, I'm eating better than I used to. And then, you know, finally, yes, we need to do the double-blind study, but we also need hope. So this is my son's contribution to my talk today. Thank you very much.